pleased to welcome Dr. Jason Kerr and Mary-Lynn Peters, who will be presenting on a collaborative approach between medicine and psychiatry for preventing and managing delirium. A brief introduction to our very accomplished clinical experts today. Dr. Jason Kerr is a geriatric medicine specialist who serves as the Division Head of Seniors Health at Trillium Health Partners, as well as the Interim Chief of Primary Care, Rehab, Complex Continuing Care, Palliative Care, and Seniors Health. Mary-Lynn Peters is a nurse practitioner who serves as the Project Director for the Standards of Care for Seniors Clinical Services Plan at Trillium Health Partners. Before we get started, I'd like to let you know how to engage with our speakers today. Please feel free to type questions you have in the chat box, and they will address them at the end of the presentation. There may be a few questions that the speakers have during the presentation, and please feel free to answer right in the chat box at that time. I'll start by answering the most commonly asked question, which is, can we have a copy of the slides and video for this webinar? And the answer is yes, you can. We'll send them to attendees and post them on our website. And with that, I'd like to invite Dr. Kerr and Mary-Lynn to take the stage.
Yep. Hi there. Thank you very much, Wendy. And thank you everyone for joining our webinar on a collaborative approach to prevention and management of delirium. My name is Mary-Lynn Peters, as you might have figured, since my co-speaker is Jason Kerr, and that certainly does sound like a masculine voice. Anyway, I'm Mary-Lynn, and I'm going to start the presentation. We'll talk a little bit about what the Medical Psychiatry Alliance is, a little bit about delirium here at Trillium Health Partners, how we've implemented this project, and then our results and what we've learned, and then we will have some time for questions. So briefly, what is the Medical Psychiatry Alliance? It is a multi-organizational project comprised of the Center for Addiction and Mental Health, CAMH, the Hospital for Sick Children, the University of Toronto, and Trillium Health Partners. This Medical Psychiatry Alliance was formed with the mandate of looking at persons who have coexisting psychiatric and physical illnesses and trying to find ways to better integrate the care needed for those persons, realizing that we very often silo care into silos of medicine or psychiatry, and often to the detriment of our patients. If you go to the next slide, please, this is a graphic of what the Medical Psychiatry Alliance is hoping to achieve with better quality of care for our patients, their families, improve morale for our care providers, and reduce costs to the system. Next slide, please. So delirium here at Trillium Health Partners, as you can see on the next slide, just a little bit about Trillium Health Partners. We are a 3-site organization comprised of Credit Valley Hospital, Mississauga Hospital, Queensway Hospital, and we have in excess of 1,400 beds if you include our surge beds. We serve the communities of Mississauga, the Halton Peel region, and West Toronto, and we are affiliated with the University of Toronto, Mississauga Academy of Medicine. Next slide, please. So this is a sampling of delirium at Trillium Health Partners prior to the launch of our Medical Psychiatry Alliance initiative. And at that point in time, our incidence of delirium in the general internal medicine population was 25%, which is consistent with rates found in the literature. We did an informal scan in the organization at that time, and the average length of stay for people who had delirium was 22 days, compared to a typical length of stay of 5 to 7 days for someone without delirium. And at that point in our journey, there was no standardization around screening, prevention, or management of delirium. Next slide, please. So with that, our goal became to reduce the incidence, severity, and duration of delirium for our adult inpatients. And our why for all of this is because, as we all know, delirium has quite significant negative consequences for patients and families. It does definitely impact the patient experience as well as the staff experience. And it is incredibly common, and a large part of delirium is preventable. 30 to 40% of delirium has been estimated as being preventable, and it is quite costly. So how we chose to do this was through a series of interventions. And if we go to the next slide, And then the next slide, I'll tell you a little bit more about the what of our project, what we will package and implement across the organization. But firstly, I'd like to take a pause and see what the audience thinks. How would you structure implementation of a large-scale project like this?
So please go ahead and type in the chat box any ideas you have in terms of how you'd structure an implementation of a large project such as this one.
Perhaps there are some who've undertaken such a journey and have some ideas that they used. Or maybe you're waiting to hear what Jason and I did.
Okay, engage with stakeholders.
Awesome, yes. And an environmental scan, yes, absolutely.
Determine what is happening in the present. Readiness assessment.
All great suggestions. I think what we'll do then is we'll just go to our next slide and we'll talk a little bit about what we did. So we did, as was suggested, we did do a readiness assessment. We did process mapping on the pilot unit that was selected for us. And what we chose to do was take that pilot unit, stay there for a year, and do multiple iterative PDSA cycles on our package, on our what, prior to then doing a phased implementation. There was significant engagement with stakeholders at every phase of the project before every new incremental implementation phase. What we did was we created cohorts of units and we spread as much as we were able, we spread each quarter. We tried to build in an implementation timeout in Q4 simply because historically that's when most hospitals are at their craziest. Q4 is usually when we have all kinds of influenza outbreaks, various other kinds of outbreaks, surge in capacity challenges. And so we recognize that the organization may not have had the capacity to absorb new change at that time. So we intentionally tried to space our timing around that. And then the third thing on this slide that you'll see is that we made sure that we were aligned with other initiatives that were going on here at the hospital, such as our best practice spotlight organization work and around the implementation of the dementia, delirium, and depression best practice guideline. And we structured it so that we would deliver our education on the units themselves rather than pulling teams away from the units. And we attended unit huddles and then were there on the unit to support practice changes as we rolled out. If you go to the next slide, you'll see a high level of our implementation timeline. As I said, we are a 3-site organization. Our scope for this project was our 2 main hospital sites, the Mississauga Hospital and the Credit Valley Hospital. And we were given the task of implementing delirium practices on all adult inpatient units, with the exceptions of the Women's and Children's Program. So our pilot unit was the cardiology unit at the Mississauga Hospital site. We were there, as I said, for a year. And then our first cohort then was also at the Mississauga Hospital site with cardiac surgery ICU, our orthopedic unit, and 3 of our rehab units. From there, we spread to medicine. And with that, we then became dual-sited when we spread to the medicine program at Credit Valley, which was also an implementation challenge for us. To run sequential projects at 2 sites required 2 sets of teams and a significant amount of project management, logistical support. We have, as you can see, for this fiscal year, we will be going to intensive care, mental health, and oncology, and that will wrap up the scope of our original mandate. If you can go to the next slide, please. So our what we chose to implement on those units was in 4 main buckets: assessment of delirium, prevention of delirium, management, and then transitions of care. And so those 4 buckets really come down to 2 main streams of work: direct care provision and consultative care provision. If you go to the next slide, What we have used is a stepped care model for delirium, and this is a model that is often used in primary care and in mental health care, and we've kind of borrowed it and tweaked it a little bit to make it work in the acute care setting. Our first level of the step is around the prevention and recognition of delirium, and that is being done by the teams on the unit, our point of care staff. And that involves things such as the preventive strategies of getting patients up in a chair for meals, making sure they, what we call, walk around the block or ambulate regularly through the day, that the lights are on in the daytime, off at night, that they engage in something called 10 at 10 that I will tell you more about in a minute, and that delirium is screened for once a shift. The next step in this model is around, if delirium is recognized, our delirium order set is utilized by the MRP or the nurse practitioner on the unit. And then the next step up would be, if that team felt that they required the assistance of our delirium team, they would become involved. And so the top two tiers of this stepped model are the delirium team. And the team is a nurse practitioner and an occupational therapist, a geriatrician, and a psychiatrist. The team holds rounds twice a week, and complex cases are reviewed with the two physician consultants twice a week, but the majority of the cases are managed by the NP and the OT independently. They do link back, as you can see on the left side of the document. There's a loop down to the MRP step. They do connect with the MRP regularly when they've made their assessments and share their recommendations and findings with the MRP. If you go to the next slide, this is a little bit more about what our 10 at 10 is. So this is something that we borrowed from our rehab unit at the Credit Valley Hospital site. It is based in evidence. There is significant literature to support the positive impact that music and movement can have on persons with dementia and on depression and anxiety. We took a little bit of a leap to think that this might make an impact on persons with delirium, recognizing also that dementia and depression are also risk factors for delirium, and so there is a logic to why this might be efficacious in this patient population. What it involves is twice a week on the acute patient units for roughly 10 minutes at 10 a.m. Patients are gathered to a centralized local area on the floor. Music is played, which is music which is relevant and meaningful to that age group. And there is physical activity, seated physical activity, that's led by the team members. So this gives patients an opportunity to get out of their rooms, to have some socialization with other patients, with the staff, to hear some music, maybe see some sunshine, and get some therapy all rolled into one. And it typically ends with a little bit of orientation. Can anyone tell me where we are, what day it is, and what I like to call a dad joke. So some kind of basic pun or little joke that might make most of us groan, but would give a little giggle and a bit of a smile to people. So if we go to the next slide, this is a little bit more about what our delirium team is. So as I said earlier on, when I was talking about our stepped model, the delirium team is a nurse practitioner, an occupational therapist, a geriatrician, and a psychiatrist. The initial assessments are performed by the NP and the OT, or the OT. They are able to practice autonomously and independently. Most of the cases will be seen by them, and in point of fact, we chose not to call this a consultation team, because when our physician partners hear the terminology consultation team, to their mind it means that a physician will be seeing this patient, and that is not the case with this delirium team. We are choosing to reserve consultation by physician for those small percentage of patients who are quite medically complex or have a very complicated psychotropic medication regimen. So we are calling this team a delirium team, and the NP and the OT, or OT rather, will do the lion's share of the assessments. As I said, they round twice a week, and the complex cases are discussed. And the team is consultative in nature. So they swoop in and swoop out. We'll go in, follow the patient for a few times to make sure that the recommendations are appropriate, and then leave the care to the MRP and the team on the floor. And all the while, there's an expectation that the delirium team will do local capacity building and in-the-moment teaching. both the NP and the OT, as well as the physicians when they are consulting on these cases. And next slide, please. This is an example of something that our Delirium team created to share with patients and families so that they would know that their patient, their loved one, had been seen and assessed by the Delirium team. This is a little cardboard tent card that is left in the patient room after the team has been in and done their assessment. It has, as you can see on the blue section there, it has some very generic standard kinds of suggestions that we would make for someone with delirium. What you can't see is that on the inside of this tent card, there are lines and a section for the Delirium team to write customized implementation strategies or prevention strategies, such as make sure that he has his glasses on, or make sure that this person is sitting in a chair for breakfast, or talk to them about the Blue Jays. Next slide, please. So now I'm going to talk a little bit about how we have implemented our what, which I just spent some time sharing with you. So if we go to the next slide, you'll see this is a sample of what we would present to the leaders when we engage with them. So earlier on, we asked what some of your thoughts on an implementation strategy would be, and I heard stakeholder engagement coming through from you. And this is how we did some of our stakeholder engagement. With the program directors and managers and educators and charge nurses to go through what exactly it is that we would be asking of their team. So this slide breaks it down in that we would be asking their team to attend delirium education, and there's an example there of how we would deliver that education, that we would then, the next month, we would ask them to start screening for delirium. Then a month after that, once they've got the delirium screening well and truly entrenched, hopefully, they would begin implementing some of our prevention and management strategies in a phased approach. Next slide, please. This is another example of what we shared with that leadership team for each unit when we went there. So how we support the team after that ask of what we're asking from them, we will support the team with unit-based delirium champions. So these would be selected by the unit leadership. We ask them to select 3 nurses and 1 allied team member for each unit, and then they would be attending a 4-hour delirium workshop. And in that workshop, they would learn about delirium, dementia, and depression, as well as how to be a champion and what the expectations of a champion are. We would also support the team through our delirium team with their attendance at unit huddles, presence at delivering education, and local support in the moment. And then, as mentioned earlier, our best practice guideline team, very strongly involved with the education delivery, attendance at unit huddles, and being on the units to provide real-time Q&As. Next slide, please. This is just a sample of some of the things that we've done to try to create a buzz at the hospital. Some of you may be aware that March 13th was World Delirium Awareness Day. We worked with our communications department to create this poster and held a CAM screening rate during the week of March 11th to 15th with the promise of a pizza party to the unit that had the highest scores. And let me tell you, I was amazed at how, let's just say, how cutthroat? No, how keenly the units took to this. They're very competitive people. And so we had a lot of engagement with this CAM screening challenge, and there was very fierce competition for the pizza party. And one of our medical units won the pizza party with a 100% screening rate for the entire week. So they very rightfully earned that party. But this poster, doing the screening party, helped to create some organizational buzz. And we've actually had some of the educators email our team to say, okay, what's the next challenge? What can we do next? So I think that was a very positive strategy that we used. If you go to the next slide, there's a little bit more about what we did for World Delirium Awareness Day. On the left-hand side of the slide, you'll see a photo of knees, people sitting in wheelchairs. That's an opening shot from a video that our communications team did with us to highlight delirium. And Dr. Kerr was one of the stars of the video. along with some of our occupational therapists and the teams on the units. And 10 at 10 was filmed as part of this video. Then the right-hand side of that slide shows what was on our hospital intranet webpage. There was a hashtag, there was a challenge for people to post selfies, and then there was some basic information about delirium prevention. And you will recognize, I hope, that lovely circular graphic from the Regional Geriatric Program of Toronto. Thank you very much for giving us permission to use that in our work. Next slide. So all of this, obviously, there has to be a component of education. And so now I'll talk a little bit about how we did some of our education with the team. So on the next slide, the content that we delivered was how to use the screening tool. And the screening tool that we selected is the Confusion Assessment Method, or the CAM. We taught about what delirium is, how it can be prevented, how you can manage it. And then also for the champions on the units, we taught them how to be a champion. We delivered this education in a variety of modalities. We offered coffee break sessions on the units on day and evening shifts. We delivered lunch and learn sessions and had free pizzas for those attending those, because as we all know, if you feed people, they will come. So we had pizza lunch and learns. We also offered some skills day sessions. We had a behaviors fair that was offered over a 1 month period at all 3 sites, with a variety of drop-in days to learn about responsive behaviors of dementia, to learn about delirium, to learn about constant care, to learn about restraint minimization and fall prevention. It was all grouped in together in this behaviors fair. We have created also some learning modules through the Medical Psychiatry Alliance Collaborative Care Certificate Program. That's the MP3C that you see mentioned there. We had a delirium module, as well as a responsive behaviors of dementia module that were created specifically to address those topics. And an online e-module is in the process of being created as we speak. We also went to the units for their huddles, and we went to their program rounds. Our physician colleagues were engaged at their various division meetings and program meetings. And as I mentioned, we had the 4-hour Champions Workshop. We had a lot of support from our communications department to create some eye-catching posters. We created lanyard cards, pocket cards, the tent cards. We have a decision-making algorithm, and then specific for the champions, we created a workbook for them that goes through in-depth material on dementia, delirium, and depression. Our goal was to educate 80% of staff on all of the project units, and for the most part, we were able to achieve that. There were 1 or 2 units where we weren't quite able to reach 80%, but by and large, we did that. And since our launch in August of 2016, we have educated more than 1,750 staff. Next slide, please. This slide is just to give you a visual, to show you what one of our printed materials look like. This is the poster that is on all of the units, and it's our Let's Stop Delirium poster. And it goes into some of the high points of non-pharmacological management and prevention of delirium. So communicating clearly, managing pain proactively, making sure that people are eating and drinking, that their bowels and bladder are working well, that they're mobilizing, that the environment is healthy and conducive. And so with that, I am going to go on to the next slide, and I'm going to hand over to my colleague, Dr. Jason Kerr.
Hi, everybody. So the work is great. It was a lot of work to be done, a lot of heavy lifting. So I'm sure what you all want to know is, did it work or not? And are we seeing tangible results? So that's what I'm going to talk about now. So on to the next slide. So this is really just kind of like our table 1 in terms of demographics. So we have on the in the left column, basically different variables for each patient. And then in the 2 columns on the right, we have whether they were present for delirium or absent, and that's of course using our CAM screening. So just a couple of things that I want to point out here. Nothing except for one variable that I'll talk about in a second really goes against the literature. So for example, we know that people who are older are at higher risk for delirium, And indeed, in that kind of third row there, you can see that our average age for CAM positive patients was much higher than those where delirium was not present. We do have a couple of other interesting findings. So unplanned admissions in terms of people coming in through the emergency department obviously had a higher level of delirium versus those that were planned admissions. It wasn't statistically significant, but very pertinent to what's happening in Ontario now. We did find that people who are in unconventional spaces, so those are the people in the hallways, we actually have a gym that we open up every winter for flu season, much higher rates of delirium in those patients. Just the sample was quite small, so maybe that's why it wasn't statistically significant. And the one that I do want to point out is the male and female breakdown. So I believe in the literature, typically males are at higher risk for delirium, but we actually found that females were slightly higher in terms of incidence of delirium at our site. So we'll move on to the next slide. So another question for everybody. So what metrics would you track if you were doing a project such as this?
Dr. Kerr, it's Wendy. We've just had a request if you could speak just a little bit slower. That would be great. Thanks.
Will do. So we have days from admission when assessed. Ooh, number of patients and restraints. I like that one. How many days patients are CAM positive and length of stay. So for sure, the duration of delirium, very important. Okay, so those are pretty good answers. I think I'll move on from there. So next slide. I'm just going to close our little chat box here. So these are the early results on our pilot unit. So as Mary-Lynn mentioned, this is the 2C cardiology unit. We're looking at the blue is August of 2016, and the kind of orange is July of 2017. And really what we're looking at is adherence to, is this up in a chair or is this?
Yeah, so up in
a chair, right, up in a chair. So the first one is up in a chair. Again, at our institution, I'm sure a lot of people can relate to this. You know, before we started this project, there were cultural practices, you know, within the staff that really were not kind of keeping up to the latest evidence. So it was actually pretty rare to have people up in a chair for meals, as you can see. And then you can see the adherence to that recommendation really did skyrocket with the intervention in July 2017. And obviously the next thing is you can't improve a problem if you can't measure it. So the biggest really, and we're still doing this, the heaviest lifting really is just getting our frontline staff to understand the importance of screening people for delirium. So actually doing that CAM score every shift. You can see prior to the intervention, the rates were extremely low. And obviously post-intervention, we're up to about 80%. And we'll talk about different units in a moment. So we can move on to the next slide there. So this is the monthly CAM screening rate on our pilot unit. And, you know, in the interest of full disclosure, our pilot unit is definitely our best unit, mostly because they did receive a significant amount of attention for about a 6-month period before we really started spreading elsewhere. But you can see here, going back to February of 2017 and looking at maintenance really. So the CAM screening rates, both on day shift and night shift, do remain really just about 80% and slightly above. So we're pretty proud of that because that's a big change compared to the pre-intervention. And we can go to the next slide here. So monthly delirium rates on our pilot unit. Again, this is kind of the main result. So you want to see less delirium with this intervention. So you can go back to February of 2017, looking at the CAM positive scores on the day shift and the night shift. They're hovering at around 4 to 5%. And as we move on with our intervention, they have steadily come down. And this is actually a significant decrease, statistically significant. Now, I'm not going to sit here and claim that only 1% of our patients have delirium on our cardiology unit. If that were true, it's a model that should immediately be replicated throughout the world. We definitely still have issues with appropriate administration of the CAM in terms of false negatives. But overall, we are very confident in saying that this is a trend downward, and it is statistically significant so far. And we will talk about some of the auditing that we're doing to ensure accuracy of the CAM screening. We'll move on to the next slide there. So this is monthly CAM screening rates in our first cohort. So this is our cardiac surgery ward, our orthopedics ward, and our 3 rehabilitation wards. So again, just demonstrating that as the intervention has started up, we're looking at about 50 to 60% of our patients being screened with the CAM. And then again, going over the past year, steady increases, and we're up to about 90% on a monthly basis now. So again, we have been able to retain that screening rate. Most, if not almost all patients are being screened for delirium on those wards now. And this is not our pilot unit, just to point that out. So they had less attention, but still able to maintain those numbers. Now, looking at the delirium rates in cohort 1, again, another statistically significant decline. If you look at February 2018 versus March 2019, again, I don't believe that the true rate of delirium is less than 1% on these wards, but certainly we have noticed an improvement in the actual CAM screening. We move on to the next slide. So one more slide, sorry. Thank you. So our monthly CAM screening rates for our second cohort. Now, which beds are these? So this is our medicine unit. So this is 9 units across both sites, and it's about 340 beds. So a pretty large kind of cohort of patients here, and certainly an area where delirium is very, very common. So you can also see here that we have had improvement, perhaps not as much improvement as on our previous cohorts, but still significant, going from about 50% at the beginning of the intervention to almost up to 80% in March 2019. And again, that's only about 6 months. So we still have some room to go there. So next slide. All right, so then our, again, delirium rates. So just to split this up, you can very clearly see there is a trend downward in patients who are screening CAM positive. And again, we take that to mean reduction in the incidence of delirium. The statistical significance here is for the day shift. So I believe the night shift is not technically statistically significant, but still a trend downward and improvement. So we can move on to the next slide. So the sharing results, and to me, this is one of the most important slides that we have. One of our big lessons from the pilot unit is that, you know, it's great to go on a unit when you have 40 beds and you have a very large team, and basically every day you're reiterating how important it is to do delirium screening to get patients up into a chair. As we've moved through the project, I've had, you know, disappointing things happen. I just want to give a quick anecdote. So even on our pilot unit, there was a new charge nurse who approached me about 2 weeks ago and said, you know, Dr. Kerr, what is the CAM? What should my nurses be doing that? And it's really, you know, through no fault of her own. It's really just because, you know, she's new to the organization, and part of this retention, part of ongoing improvement and sustainability is making sure that we educate everybody, right? So what this chart basically shows is who gets the reports here. So if you look at the first row, the CAM completion report, so the educator on the ward receives that, and they get it fairly frequently, so 3 times a week. And it really is up to them to say, oh, I wonder why our CAM completion rate has dropped. Then they'll be going around to the frontline staff, trying to figure out why, providing that education on how to do the CAM, why the CAM is important. The second row here is our delirium dashboard, which we'll show in a second. So that includes the CAM rates, the rates of positive CAMs, and again, how much non-pharmacologic strategies are actually being used. So the level of spread there is higher, so the manager actually gets that, and they get that on a weekly basis. The organization is heavily invested, especially in the non-pharmacologic strategies. So as you can imagine, the manager will be highly motivated if they see that, you know, only 10% of people were put in a chair for meals. They'll want to find out why that's not happening, and they'll want to correct that. The third row there, the CAM completion rates monthly. So that goes to everybody. So the director, again, who the manager reports to, it goes to the manager as well, and to the educator. So the director, again, is just an extra layer, getting higher up in that administration and getting the buy-in to support the delirium project. And then there's also the CAM completion rates quarterly over the past 3 months, where they can get a better idea of trends. And again, all 3 groups receive that. So we'll go to the next slide here. So this is our dashboard that we talked about previously. So you can see there's 4 different areas here. So in the top left corner, you have the final CAM score completion rate. The next one over on the right top corner, you have the number of patients who had a positive CAM, and the breakdown is always by shift. Then in the bottom left corner, number of patients getting assistance for daily mobilization, again, important in terms of the non-pharmacologic measures. And finally, in the bottom right corner, the amount of times that reorientation is being provided to each of those patients. So again, we're looking at our actual hard outcomes in terms of delirium incidence measured with the CAM, looking at screening rates, but also looking at our process outcomes. So how many people are getting up to a chair? How successful are we at getting our team to understand the importance of the non-pharmacologic measures? And just a big thank you to our decision support team, who's been instrumental in getting these out in a timely manner. So Mary-Lynn talked about 10 at 10. Again, it's a very successful intervention. It is something that both the staff and the patients greatly enjoy. So we just always like to brag about that. So we can go on to the next slide. And just wanted to kind of let you know about some feedback that we've got. So I'll just read out kind of on the left side. You know, I see the staff are much more engaged in getting patients up. And also the staff are talking amongst themselves, saying things like, did you see my patient, you know, doing 10 at 10 today, dancing? She's normally in bed, like she looks great. She looks so much better when she's out of bed. So again, we can tell people all we want about how important it is to mobilize, but when like our frontline staff actually do it, the success rate is much improved, and they really see the difference in their patients. Another one that was really important, and this gets into, you know, music and cognitive impairment. Patient was not really communicating with me. When we walked him, it was a challenge. We're having a very hard time. But as soon as we put him in 10 at 10, it was like he was at a party. We saw a phenomenal change in him. So again, 10 at 10 has been very successful and something that we implement on all of our wards. So we can go on to the next slide. So what are our, our lessons learned you know, from this project? That's the most important takeaway. So the awareness and attention to organizational priorities, and this is what Mary-Lynn talked about. Really, every hospital probably in the province is going to be dominated by capacity challenges, and there's going to be a ton of work that always goes on around that. So, you know, positioning ourselves by saying delirium is one of the biggest drivers of extended length of stay. This is not extra work. This is work that will benefit the organization, you know, overall. That's a good way to get buy-in, but that it's very important to have that awareness. I see some people have asked questions about electronic medical records, and so just on that note, we're about to enter a huge project of totally redesigning our health information system over the next year. So as you can imagine, that is a top organizational priority, and definitely will have an effect on something like this project. So the engagement, again, engagement is critical. And Mary-Lynn just loves the picture of the baby here, so she wanted to include it in our presentation. So is it top down or bottom up? And really the engagement has to be both, right? So we found this out pretty early on. It is so important to get our frontline staff to realize that when you perform these non-pharmacologic measures, when people are up to a chair, when you take out the Foley, when you take off the restraints, there is definite improvement. So we get buy-in that way. At the same time, there are some people who can be very stuck in practice patterns. And I'm sure, as you all know, there are some voices on wards that can be a lot louder than others. And when those loud voices are the ones that are kind of contradicting your project, it becomes difficult. And that's when the top-down approach becomes very important. So, you know, convincing our senior leadership that delirium is a problem at Trillium Health Partners. It contributes to length of stay. We need your support in trying to fix it. That was instrumental. So getting that support from the bottom and from the top is extremely important. Then the last point here is about the pace of your implementation. Again, you don't want to go too fast. You don't want to say this is an absolute success and we're now going to spread it. You know, one of the lessons we had is our pilot unit worked very well. And at one of our executive meetings, our CEO said, well, if this is going so well on one unit, why am I not doing this for every single patient in the hospital? And like, that's great. And you're absolutely right. We should be doing it. That did lead us down a path of trying to implement things a little more quickly, and probably did affect the fidelity of our project. So we've had to do a lot of work kind of going back and reiterating and trying to maintain that sustainability. So it can be a bit tricky. You don't want to go too slow, but again, going too fast can sometimes torpedo the whole thing. So we can move on to the next slide here. So key messages from our talk. So delirium is everyone's responsibility, right? This is not something that falls to the RPN, just to the RN. It doesn't just fall to the OT, the PT, the physician. It's really everybody, and we all have to work together. I always tell my physician colleagues, you know, if you don't like dealing with delirium or dementia, then I've got bad news for you for the next 30 years, because that's really a lot of what you're going to be dealing with. It is much easier to prevent delirium than to treat it. This is why we focus so much on our non-pharmacologic strategies. And multi-component interventions really are the most successful. I wish that we could give you a magic bullet and just say, if everybody did this one thing, there would be no delirium. but that's probably not going to be the case. We have to kind of attack it from many, many different angles. So I don't know if Mary-Lynn wants to add anything to our key messages.
No, what I would add is just that we have taken what was in the literature and taken it to heart. So the multi-component intervention, rather than just trying to launch a delirium team that would only look at, for example, psychotropic medications, we have intentionally gone multi-component. We have intentionally accessed things that were also in place at the hospital, like our hospital elder life program that's on 12 of our units, like our best practice guideline group. We've linked into those kinds of things. So we've been very strategic about this and trying to find ways to embed it into our ways of doing, so that hopefully it will sustain long after Jason and I are gone. That's the hope. Anyway, we do, in our original mandate, we have 3 areas left to hit, and we will do them this year in Q2, and that's our mental health program, our intensive care units, and the oncology program. And so by the end of this fiscal year, we will be in all adult inpatient units at this hospital. So fingers crossed for us.
So I guess at this point, we're happy to take any questions. We'll maybe turn it over to the facilitators.
Sure. There are lots of questions. This was a very engaging presentation. There's a few themes that are involving, so we'll address those first. One is the sharing of tools. The webinar slides and video will be shared, but people are also asking if you'd be willing to share the tools that you created, like the video, the Delirium toolkit.
Absolutely.
Great. And how would they best get those? Should we email them out? Can they get them right on your website?
That's a good question. Can we
might
get back?
Yeah, I have to think about it.
No problem. But thank you for sharing tools. It's so important as healthcare providers that we really collaborate and share what we have. And in that theme, I'm wondering, how much did you have to create yourself versus what you found available already?
It was a blend. There, as you know, delirium is very widely studied. So there are materials all over the place. We took bits and pieces and we kind of blended, and then there were some things that are just purely homegrown. It's a mix.
Okay. A lot of people are asking about the measuring of non-pharmacological measures, such as up in chair. Did you measure them? And if so, how did you measure them?
We did. So initially we used what I call the secret shopper strategy, which is I would just parachute onto a unit one day, walk around at lunchtime and count numbers of people up in a chair for lunch, and then relay that back to the educator and the charge nurse on the unit to say, hey, 8 of your 40 patients were up in a chair for lunch, or 30 of your 40 patients were up in a chair for lunch. And so that's one strategy is just the actual physical eyeballing of it. And then the other is that we have set up in our Meditech system and the system that we use at the other site, which is called Sunrise Clinical Manager. There is a space after completion of the delirium screen where they can document what non-pharm strategies they intend to implement for the day. So we also can pull that electronically by our decision support team.
Okay. There are a few people asking how you were looking at CAM accuracy, and if you did look at CAM accuracy. And there were a few comments about sometimes CAMs aren't accurate because people don't have an adequate knowledge of the baseline, for example, if patients have dementia.
Agreed. And so we intentionally went about this with a 2-pronged approach. The first being, let's get people talking about delirium, let's get people thinking about it and doing the screen. We obviously hoped they would have good accuracy at that time, but we recognized that they might not. And so now we are in what I'm calling the quality double down in Q1 of this year, and we are doing audits on the units where our delirium team and our best practice guideline champions will be going onto the units and performing CAMs side by side with teams. So we're looking at the accuracy of their assessments in this quarter.
Great.
So I just want to add on to that quickly, because that really is a great question. Like the accuracy of the CAM is definitely something that we have struggled with. It is very, very hard to roll it out to such a large organization and ensure the fidelity. And right now, as Mary-Lynn said, the emphasis is on auditing. But again, in talking about our slides, I'm by no means claiming that we have like a 99% success rate with Delirium. We know that there are definite false negatives, and that's why it's so important for that ongoing education piece.
Great.
And I would add that to that ongoing education, we also have Delirium education built into the hospital orientation. And we are, as I said, working on some e-modules so that there will always be educational materials about Delirium available.
Well, that's great. And that actually leads into another question that somebody had about how you make sure new staff or agency staff are aware.
There we go. And sorry, go ahead.
Yeah, no, please go ahead if you wanted to say more.
Yeah, I think that was so, and we have noticed that. My kind of anecdote got to that. In terms of new staff, we do have a full Delirium orientation as part of the broader, I think it's a 2-day orientation when you start to work at Trillium Health Partners. So we were successful in getting into that. So all new staff should know about the CAM. They should know about the expectations for screening. I'm not sure why the one person I mentioned didn't, but that's the reality. I think for agency staff, it's a little more difficult. I'm not, maybe Mary-Lynn, if you know, do they get that orientation or not really? Yeah. So that is an area that's lacking, or our agency staff really don't get the education yet.
Okay, there's a few questions about how this links to the Hospital Elder Life program.
So we do, as I mentioned, we do have the Hospital Elder Life program. It's on 8 units at one site and 4 units at the other. And it links in that as Jason said earlier, you don't find what you're not looking for. So the Delirium screening actually helps the teams on the units be more aware and to be more thoughtful about their patients. The Hospital Elder Life program sees a smaller subset of the patients on the unit, and so takes a proactive approach to that subset. But this supplements and augments the work of the Hospital Elder Life project by looking at every patient on the unit. So I see the two as going hand in hand.
Okay. There are a couple of questions about restraints. Were you capturing any information about that? Did you see restraint use go down?
We have not at this time, but that is a difficult thing to track, given that it's electronically documented at one site and paper documentation at the other site. That one we're still working on.
Okay. People are also asking about a correlation with length of stay.
So yeah, I mean, typically in the literature, what I always say is, delirium prevention strategies, or delirium itself, usually extends stay an average of 2.2 days. So within our group, I don't think that we've seen a statistically significant decline in length of stay yet. Again, I attribute that to really just working on our accuracy in terms of identifying those patients with delirium and just more time to get more data. The other problem that we have with evaluation, evaluation is a huge part of this. It's been very difficult to have a true randomized trial, right? And we have a whole Institute for Better Health that's kind of devoted to that. We went through so many different iterations of how we could evaluate this. It's pretty difficult. Essentially what it often comes down to is a before and after study. And as you all know, in a before and after study, there are many things that change. So it can become difficult to attribute that change just to your project. So the evaluation is something that we're still working on, but haven't really fully been able to do that, as proficiently as I would like at this point.
You've definitely collected a lot of great information to this point. So it's, like you say, it's always an ongoing process in terms of what you want to measure and how you want to evaluate, right? There's a couple of questions about the team structure. One is how many staff members, professional practice educators, etc., made up your rollout education team for this project?
Oh, the rollout for the education. Oh, that was a big lift. On our initial pilot phase, it was myself and and our best practice guideline team. So there was a core element from that team. So there were perhaps I think 8 of us on the pilot unit. As we have spread beyond the pilot unit and we recruited our Delirium team, they were roped in to the education duties. I would say we've had a core team of anywhere between 8 to 15 people who've been delivering the education across 2 sites.
Okay, and that answers actually a couple of other questions. How many sites did you do this at each site, or it's now rolled out to 2?
It's on 2 sites, and we have a Delirium team at each site. So each site has an NPOT, psychiatrist and geriatrician dedicated to the Delirium project, and 1 project manager who oversees both sites.
The questions are still rolling in, and we're coming near the end of the hour. But we'll try and get through as many as we can here. Another question in terms of what types of huddles do you discuss CAM positives at? Are they bullet rounds, leadership rounds, or safety huddles?
It's a bit of each. We do go to the units bullet rounds that they have daily. We have also, for example, presented at various leadership tables. Our patient services leadership team, we've presented at Medical Advisory Council, senior leaders. Anybody that'll hear us will go to.
Great. There was a question here about how are you holding staff accountable? So you've spoken to that, I think, in your presentation a little bit. I don't know if there's any other tips that you might want to share in terms of holding staff accountable.
Yeah, so our senior leadership always talks to us about hardwiring, this process in, and it's actually something that's so easy to be said and very, very difficult to do. But this is where you really need buy-in from leaders on the unit, and I'm talking about the educators really and the managers. If you don't have that, it's very, very difficult to convince people at times. So we've had a lot of comments like, this is cardiology, we save lives here, or this delirium work is just fluff. Not that I'm saying this is fortunate or not, but what has helped us right now actually is there have been some critical incidents identified in the hospital that would have been totally avoided had CAM screening been performed properly. And these are very unfortunate outcomes, but actually demonstrate to all staff that, look, if you had done this, if you had learned how to do it properly, this outcome would have been totally avoided. So it takes a combination of all those things in terms of the accountability.
Great.
And also, I would just chime in and say, some of the units have put this on their quality boards as quality board indicators. And so then there's peer-to-peer accountability, as in, why aren't we green today? Why didn't everyone do their delirium screen? So that's another way.
That's a great way to drive accountability, and also sustainability, which others are asking about as well. Are you seeing sustainability?
Right. And so the place where we are very encouraged is on our pilot unit, because as we said, we were able to devote a great deal of attention and manpower hours to that pilot unit for the first year. And then we've kind of had to back off as we spread to all these other areas. And yet the practices have been sustained there. Their screening rates are still consistently over 80%. So that's very encouraging.
Great. I think we'll just take one final question here before we wrap up. How do you engage patients to participate in the 10 on 10?
That the team on the units have been doing that. They've been selecting patients based on those that they feel are vulnerable or frail, and they just select them and ask them and take them out. And what we've had, there have been some cases where patients perhaps have declined to participate, but somehow heard the music playing or were out of their room and saw it, and then on subsequent days said, no, I think I want to be part of that. So it's word of mouth.
So it's got some natural spread because it looks interesting and exciting.
Yeah, and it's, hey, let's face it, hospitals are boring places. If you're not being shuttled from one test to another, you're spending a lot of time in your room. So this is a nice diversion.
Wonderful. Any final comments or thoughts that either of you would like to add before we wrap up?
No, just thank you so much for the opportunity. And yeah, it's great to see all the questions. It makes me really, really happy to to see other people who care about delirium as much as we do. So thank you.
Absolutely.
It definitely looks like an audience that cares, and I'm sure they're very appreciative of all that you've shared. And just as a reminder that there will be a follow-up email for all attendees, so we'll put you in touch with how you can get access to the resources that Dr. Kerr and Mary-Lynn are willing to share, as well as a copy of slides and the video. So thank you again very, very much for this great learning opportunity and for sharing all that you have. And thank you for everyone for attending and for your great engagement in this wonderful webinar. You're going to receive a short evaluation survey by email, and we'd ask that you please share your suggestions and topics for future webinars with us. And we'd also like to invite you to attend our upcoming webinar on the Senior Friendly Care Learning Series on June 28th, and registration information for this webinar will be emailed soon. And with that, we'll sign off. Thanks again, and we'll see you next time.